today to welcome our friends from Santiago de Chile and also from Madrid. Thank you, Rene, Jorquera, and Pedro Delgado for accepting to join with your teams. So today we will focus on two original clinical cases, as usual. We will have the first case presented by Paula Ramirez and Rene Jorquera. And following this, we will have the case presented by Ruben, Contreras, and Pedro Delgado. It will be very interesting cases. I would like, of course, to thank everyone, the speakers for preparing the cases, the panelists. We have a lot of panelists today. They are very important for the debate with the comments. And also my co-moderators, we have, as usual, Gustavo Gomez, Lucian Marcovici, Lorenzo Mernini. So hello, everyone. I would like to remind you that our sessions are really interactive. So please, it's very important to engage and submit all your questions and your comments in the chat. And today, Lucian will manage the Q&A session. We have also the polls. Make sure to answer the calls during all the webinar. So once again, thank you, everyone, especially the friends from Latin America. I think it's very early for you. So I think it's time to start. I will hand it over to Gustavo. So Gustavo, the floor is yours. Thank you, everyone. Enjoy.
Okay, thank you very much, Haram. So I'm very happy to be here with all of you. So I want to first, yes.
Yeah.
So I want to ask Paula if you can share your screen. Okay, so Paula worked in Chile. She worked with Rene Jorquera, so she's going to present us a case, and we are going to discuss how are we going to study the case, and how are we going to proceed with the treatment. Okay, Paula, please.
Can you hear me now?
Perfect.
Yes. Yeah, so thank you for the invitation. Today I will be discussing the arthroscopic management of the small carpal bone fragments when ligamentous integrity is present. This is a 49-year-old right-handed male patient who works in a mine in northern Chile. He presents with a 1-year history of dorsal wrist pain on the left side. He denies rest pain, but reports 5 out of 10 on the pain scale during physical activity. Good range of motion, as you can see. Dash score was 45 and grip strength is 14 kilos on the right side and 6 kilos on the left side. He reports being immobilized for a period of time and having completed 10 physical therapy sessions, but the pain persists. So these are the X-ray. What can you see? Anyone?
I think, Gustavo, we can ask someone.
Oh, sorry, I was mute. I would like to ask, I would like to ask to Juan Pablo Rojas. What do you see here, Juan Pablo? Okay, Francesca? Me?
Hi, everybody.
Hi, Francesca.
Yeah.
Good. So there seems to be an issue in the radiolunate articulation. It seems some type of arthrosis on the AP view, and then on the lateral view, I don't know if the scaphoid is slightly flexed, but also the lunate seems to be. I don't know if it's normal or if there is a bit of a VZ deformity. I think I would need an MRI to be more sure.
Okay, thank you. Mohammed Al Hassan, what do you think about this?
Yes, agree with Francisca. On the AP, there is arthrosis in the distal radius, especially the articulation between the distal radius and the lunate, collapse of the radiolunate space, and some rotation of the scaphoid. This is in the AP. As well, there is ulnar deviation or translation of the lunate, escaping the drug line. This in the AB, and in the lateral view, we can see the busy rotation of the lunate with the scaphoid as well. Yeah.
Okay, great, nice. Pedro, do you want to add something?
No, I think everything was told. The most important now, you have a busy deformity of the lunate, a little bit more with ulnar dislocation, with a little space in the radiocarpal joint, okay, in this area, and probably also a small increase the side of the gap between the scaphoid and lunate. Probably in the dorsal aspect. Probably we need another image to take care about this general situation now.
Good. So
Okay,
I'll
great.
continue.
Yes, go on, Paula.
Yeah, the radiographic findings suggest degenerative changes in the radiocarpal joint, as you said. And the question time, would you do a further study? Maybe other X-rays, bone scan, CT scan, MRI?
Just to tell you, I launched the poll, so we will see what the attendees think about this.
Yeah, I think that everyone agrees that we need more study, right?
Yes.
So the CT scan shows joint space narrowing, cartilage wear, and subchondral sclerosis in the lunate fossa with a neutral ulnar variant. The MRI also shows a subchondral cyst in the lunate and bone marrow edema on the ulnar side of the radius and lunate, which are consistent with the diagnosis of the radiocarpal osteoarthritis. So question number 2, what do you think? What are the diagnoses of this case?
Okay. Is Ruben Contreras?
I can go back with the image.
Yeah.
Yes, please. Yes, yes. Can you hold the MRI there? Okay, Ruben, can you hear me?
Yes, I'm hearing you.
How are you doing, Ruben? What do you think
here,
about this?
In this case, I look osteoarthrosis of the lunate fossa of lunate in the radius, and we can see a cyst in the ulnar side of the lunate. We maybe the patient is presenting impingement of the ulnar carpal or abutment syndrome, because we can see that the head of the ulna is impacting or is making an impact in the ulnar side of the proximal lunate.
Okay, thank you. I want to ask to Alfonso, how will you proceed with in this case?
Hey, hello everyone. Can you hear me okay?
Yes.
Yeah, thank you. Well, yeah, probably I don't think the problem is the impeachment on the ulnar side, because when you have an impeachment, probably you don't have that kind of osteoarthritis in between lunate and distal radius. So probably it can be mixed in between radiocarpal instability plus the ulnar impeachment because of the translation of the carpus. So yeah, I think those two studies are perfect to see how is the joint and also how is the bone. So I don't think it's It's a proper Kienbog also. So I think it's something in between. It's so probably the problem is in between the radius and the lunate. So I will proceed for something in between both bones. Let's see how it goes.
Okay, thank you.
Sorry, Gustavo, can we have the point of view of some people about diagnosis? Because for the polls, I will show you the polls. People, they don't really understand what's happening. We have 40% of the attendees, they vote for ulnocarpal impingement, 30% of the attendees for Kienbock disease, and 20% of the attendees for radiocarpal instability. I think people that don't really, I think Alfonso gave us the answer. Maybe Pedro or Rene, you can give us your point of view.
Yes, two things.
How to analyze the case at this point. Yes.
First one.
I think it's a very good case to discuss.
Okay, I have the three things to say. First one, the most important here is not only the X-ray, but two, CT scan and MRI, because in fact there are two different images that we need to analyze. The first one, CT scan, is for the shape and the position of the bones. In this case, it's very important because you have a conflict between radius and lunate. And the second one is what happened inside the bone. For this case, it's very important to have MRI because probably in this case we have problems. It's not only in the lunate, also in the radius. This is the region of the pain. And the second one, the most important here is not the diagnosis. It's what's happened with the patient, with the pain. If the patient have now a problem in the radiocarpal joint, for this case, you need something to resolve this conflict. This is my key opinion. It's not, but in fact, here is, as Alfonso said, it's not important the diagnosis. It's what's happening with the patient and what's a conflict between radius and lunate.
Yeah, but Pedro, what do you think can be this kind of injuries initiate in the beginning? I mean, because I don't have anything clear in here. How is the history of the patient? Is it traumatic or?
In many cases, we have the same situation because, in fact, the two different diagnoses are the impingement, the radioulnar impingement, and second one are osteonecrosis of the lunate. Probably, what is the origin? It doesn't clear because there are many other concepts that will be inside, like a chondral stenosis, another disease, an autonomous disease. But probably it starts with loss of cartilage surface between lunate and radius, and then continue with the ulnar impaction of the DHJ. But it's difficult to try to assess what is the origin of this tissue.
Yep, totally agree.
I am. Sorry,
I think there is a little translation, ulnar translation of the proximal row here.
Yeah, I agree with you, Lucian. I think something maybe have caused an ulnar translocation of the carpus, maybe traumatic injury or so, and then afterwards the staff have been aware of the lunate, and because of the ulnar translocation and the positive ulnar variants that the patient have previously, then there was a sign of infection and something and piled up, and now we have this. But as Pedro said, the diagnostic isn't clear and the deed is done. So now we have to manage with what is now the problem, but probably something that evolves step by step.
I want to. Sorry.
Because
I want to add a little bit comment. We have a comparative X-rays is the same, yeah, and in my opinion, previous to the treatment, I totally agree with the comment of the Alfonso and the Pedro. The most important is the very good functional or little bit compromise of the functional range of motion and pain in the dorsal part of the carpus. The flexion and extension of and ulnar deviation of the wrist is very good. This is my problem. The symptoms and the patient is a little bit, and we have a big compromise of the radiocarpal joint in the CT scan and MRI, and the expression of my patient is a little bit symptoms. Yes, this is my big problem.
Pedro, you wanted to say something?
Yes, it's about the ulnar translation of the carpus. Probably the origin was a problem between lunate and radius, and then fixed, so because the space was very, very small, and probably in this case, the lunate stopped his movement between the radius, and probably in this case fixed it in this position, and then continue with the stroke of the ulna to the lunate. It's not important in this case the ulnar translation because probably in this situation it will be a stop between radius and ulna because it's fixed. Probably this is the condition. It's not a real ulnar deviation of the radius, is in my opinion.
Pedro or Rene, I have a question for you. What do you think about the fact that the cyst is mainly on the ulnar side? That makes a difference for you for the diagnosis because it's more for ulnar impingement than for Kienbock. What do you do with this image of cyst just on the ulnar side, which is quite frequent?
Probably in this case, probably this, my opinion is the same that Rene, because in fact, if you have only a mid part of the ulnar side of the lunate is always a ulnar carpial impaction syndrome. But if you have a complete edema of the lunate, is more compatible with Kienbock disease. But in this case, you have the two stage, the two images in the same bone. It's so difficult to try to assess with the proper diagnosis.
Yeah, it's a combined
Thank you.
diagnosis.
Okay.
Combined,
Okay, thank you.
yes.
So we need to go on. So the origin, the etiology is not clear, but we can see that we have a problem, an impingement between the radius and the lunate. So Paula, can you go on, please?
Yeah, we'll go on. So I think that the discussion was good because even if it's something between Kienbock or ulnar infection, we need to clarify the diagnosis because the treatment will be completely different, right? Kienbock disease has one treatment, and if we are thinking about a ulnar infection, we'll do different probably. So we perform diagnostic arthroscopy and found a central lesion of the TFCC without foveal stability, which is more typical of a ulnar infection syndrome, right? The lunate fossa was destroyed and the lunate was denuded. You can see damage and softened lunate, and the scaphoid fossa of the radius was intact. Also, we found intact scapholunate ligament and lunotriquetral ligament, and intact scaphocapitate and lunocapitate articular surface. So this is the question number 4, surgical management. What will you do with these findings in the arthroscopy? Remember that the patient has like a good range of motion, a little bit of pain.
Just a quick answer. Lorenzo, what will you do?
Depending on the clinical presentation, what I understand, the patient is not so bad. So given that the atypical diagnosis and the always difficult management to offer in this kind of situation, of course you can always start with the medical treatment, injections and so on, and see what happens. So I don't know if that's what you offer to the patient initially, but let's say for the hypothesis that the medical treatment didn't work, and then we have to move on to surgery. In that kind of situation, we have some good experience with biological interposition of some kind, depending on the team experience. I know Pedro have good experience with that. I know in Paris we have also some series with that. We could also consider the patient as an equivalent of Kienbock disease, even though it's not properly a Kienbock disease. So we can also do in that case a lunate arthroscopic removal, like we do in some cases. So I would go for a minimal invasive procedure, given that the patient is pretty good. If you had a bad clinical presentation with a complete stiff and painful wrist, it would be different. But in that case, I would go to to a soft procedure of that type.
Great, thanks. Paula, can you show us what you did?
So we propose, can you hear me?
Yeah.
Yeah.
So we propose arthroscopic minicarpal bone resection since the ligaments are intact. So is this possible? That's a very good question. 2 years ago, we decided to do a biomechanical analysis to study the ultraproximal scaphoid node union. We know that the proximal pole of the scaphoid is joined to the lunate by the 3 portion of the scapholunate ligament. In resarthroscopy, we've seen connections between the scapholunate ligament and the dorsal intercarpal ligament. This is the DCSS, which is believed to be important for stability. So we agree on the importance of the dorsal complex, but the most important thing is that the connections are in the dorsal surface of the wrist of the waist of the scaphoid, the distal edge of the dorsal horn of the lunate, and the dorsal cortex of the triquetrum. Another very important thing is that the mechanical value of the boral scaphotriquetral ligament along with the palmar portion of the scapholunate ligament. In the kinetics and kinematics of the carpus, the dorsal intercarpal ligament and the volar complex are essential for the stability of the proximal row carpal bones. And these ligaments form a socket, what we know today as the labrum-like concept. Along the same line, authors in the past have recommended partial resection of the proximal pole of the scaphoid, such as Mark Garcia-Elias, who classifies this micropole as type 1 and type 2, depending on whether or not there is an involvement of the scapholunate ligament, without considering the extrinsic ligament. In Europe, you are familiar with this implant with the APSI. Nonetheless, a simple resection of the proximal pole of the scaphoid could be performed, but there is a concern regarding the stability of the carpus. So, with the help of Dr. Seidenberg, we did a biomechanical study of the sequential excision of the proximal pole of the scaphoid. Under axial loading, we assess carpal alignment during sequential proximal pole resection. As we know, the scapholunate ligament has 3 portions, being the dorsal component the strongest one, which provides most of the stability to the joint. But now we know that the volar part has an important role as well, controlling the rotation of the joint. So what are our outcomes? This is the study that we did for the scaphoid, and we thought, is this possible to do it in the lunate bone? So we proposed an isolated lunate excision. As you can see here, how we delaminate the proximal pole of the lunate with the help of a shaver, and we start eating bone, right? From the 6-hour portal, we perform an isolated lunate excision and part of the triquetrum as well, because we need to make sure to unload the area where the load is being transmitted to the ulnar side of the wrist. Then we test the joint congruity of the scapholunate. So after all the procedure, we add a layer of fibrin plot to the lunate fossa. And finally, we take the volume of lunate resection under X-ray. Here, the area of contact is located on the scaphoid, and none of the load is transmitted in the ulnar side of the lunate. This is the CT scan post-surgery, after the surgery of the isolated lunate excision. As you can see, there's more space between the radius and the lunate. These are patients, 6 months follow-up. He now has not pain. He doesn't have pain, and quick dash is 0. So therefore, I think that it's very important to have well-selected patients. Intact ligaments to perform these are critical. Maintaining normal biomechanics, arthroscopy allow us to diagnose and treat all the associated injuries. Never forget about the proprioception and neuromuscular control. This is a reproducible technique, and you have to send your patient to an early rehab. Thank you.
Thank you, Paula. Very nice, very good presentation. So I tried to avoid Francisco Meliboski and Rene Jorquera during the presentation because I know they know the case, but now I really would like to hear a final comment from them about this case. Francisco, how are you doing?
Hi to everyone. Hi, Gustavo.
Hi, Francisco.
It was a really challenging patient, really, because when we made the surgery with Rene, we have a lot of possibilities to do, and with the arthroscopic findings, it didn't was a very easy decision, really. We decided the isolated resection because we think that with some tips in the surgical technique, you can have a very good results, really, with a very minimal invasive procedure, really. In this case, I think there are very exceptional cases, and this combined lesion with a etiologic very difficult to determine the definitive cause, really, but the result is very good, and the resection was very easy. But I think, and I have some problems with the for me, not patients of mine, but I have seen sometimes a little impingement between the lunate and the radius when you do a very extensive resection or of the lunate without the care of view if the motion of the radiocarpal joint is good until the surgery. So I think I think that when you do a very good surgery without and taking care of this problem, especially the impingement between the radio and the lunate, you can have very good results.
Thank you, Francisco. Lorenzo, you raise your hand.
Yeah, thank you, Gustavo. Congratulations to the whole team. It's a very smartly approached cases. I just one question: what you would have done if you had a scapholunate instability, for instance? If you discovered intraoperatively that the ligaments were not so stable, would you have done also a resection plus something, or change your opinion or your strategy?
Rene?
Can I go?
Yeah, this is Paula. It's a very good question, Lorenzo. It's the most important when you decide what is the final treatment in this patient is the arthroscopic finding. This is the most important. We have a patient without symptoms, and we have a osteoarthritis in the radiocarpal radiolunate joint, and indemnity of the dorsal intercarpal ligament and totally scapholunate ligament and lunotricutal ligament. This is the most important. When I performed of the arthroscopy, the real arthroscopy, exploration of the midcarpal and radiocarpal joint and TFCC and all ligament is the most important. when we have a compromise, for example, the polar part of the scapholunate, I think that is not possible with this technique, in my opinion. In this moment, I don't know. I don't have a lot of patients with technique. We have a 3 or 4 cases when resection of the proximal pole of the scaphoid, for example. This is not our training in this technique. And second point, Francisco comments in the tips in the technique is when you resection of the hemilunate, the prominence of the scapholunate and the proximal part of the scapholunate is very important. Present in this moment and result in fluoroscopy, and you should do resection of the proximal part of the scapholunate, and in the zone the decrease of the result in the radiocarpal joint is very important tips. I don't know if in another case presenting the same problem. No, I don't know. This is the first case. Yeah. Our experience.
Okay. Yeah. Thank you. Congratulations.
I think that, as Dr. Jorquera said, the critical point here is that the ligaments are intact. And for your question, Lorenzo, if you find that there is scapholunate stability, you cannot perform this surgery, and then I will change my surgery to lunectomy and a scaphocapitate fusion, and then you will have to tell the patient that you will sacrifice range of motion in order to treat the pain. Right?
Okay. The last comment, please. And Lorenzo, and we have asked of the Mariano Baid in the chat. I saw the question is the wafer reverse or reverse wafer the described for the Bulant in Istanbul, and when I decide inside to the intraoperative retacroscopy, when I see of the radiocarpal compromise, in my opinion, it's impossible to the treatment of the wafer reverse. Wafer reverse needs the normal surface of the radiocarpal joint. This is the compromise of the ulnar side of the lunate.
Thank you. So we need to move to the next case, but after before that, the last comment from Alfonso, who is raising the hand. So Alfonso, please.
Yeah, thank you so much. It's because I cannot understand in the beginning if we try to manage because I think it's a very, very good case. Thank you, Rene, Paula, and Francisco, because this case can help us to understand a little bit of biomechanics of the wrist. But if we don't understand the beginning of the problem, I think probably the hemiresection can fail very soon, because if all the load of the wrist remains in the ulnocarpal, in the lunate, in between the lunate and the distal radius area, so probably all the load can have the risk to fail very, very soon. So that's why I think that probably this is not the best case to perform this hemiresection, because what do you think is the beginning of this case?
Okay, thank you. Thank you, Alfonso, for your comment. I would like just to ask Lucian if you have some questions on the chat, please.
So most of the people in the chat are writing in Spanish.
In Spanish,
I want to ask you. I'm studying Spanish this period, but I want to ask you to write in English. The main question that I saw was you had an instability with this kind of situation. Would you do an scaphocapitate arthrodesis?
Someone would like to answer?
Yeah, I think Paula answered already when I asked the question.
Exactly.
Yeah.
So, yeah.
And another question, Lucien, or a
No,
comment?
because those are comments which we already commented during the case. So
Okay, thank you. I would like just to share the polls because it's very important. Actually, behind our discussion, most of the people voted for lunate excision and scaphocapital arthrodesis, and other voted for local osteochondral surgery or interposition. So it's very interesting to see how this case is the beginning of a lot of discussion. Just I wanted to add, for my opinion, in this kind of case, the less we do, the best. And I agree with Lorenzo. I think I would like to manage also the scapholunate instability. We do this kind of surgery, but for Kienbock disease, for example, it's not necessary to do a complete lunate excision, and we can add some kind of arthroscopic capsulodesis to make sure we will not have a secondary instability after. So thank you, Gustavo. If you can have can make the last comment and move to the other case, please.
Well, you said everything. I think this is very important because although we don't know the origin or the etiology, as Pedro said, it's very important to highlight that the problem is between the radius and the lunate. So we need to focus on this area. And as Alam said, we have a lot of options. This is a very rare case, and it was very well solved by our friends from Chile. So this is a very nice and good example that they bring us today. Thank you very much. So we are going to move to the next case. Ruben, I want you to share your screen, please.
Okay.
Okay, thank you. Ruben worked in Madrid with Pedro, with Alfonso, with Victor. So, and I want to hear something from everybody, Gonzalo Pintado too. So we are going to speak about this case with scapholunate and lunotriquetral injury. Please, Ruben.
Okay, thank you, Gustavo. Good afternoon to everyone, and good morning to those in Latin America. Thank you for the opportunity to present this case today. Is it the arthroscopic reconstruction of combined scapholunate and lunotriquetral tears, 1 or 2 stage surgery? To start with the case, it's about a male, 45 years old, right-handed police officer. He underwent a first surgery in 2021 when consists in a root synovectomy in another center and a chondroplasty of the triquetrum. He comes to the office team like first attended in July of 2024 with right wrist chronic pain, was with push-ups, with a run of 50 of flexion and 80 degrees of extension, with clinical impact in the dorsal ulnar wrist pain, with a positive Watson and Balloon scapholunate and lunotriquetral test. This is the preparative images of MRI of the right wrist.
Okay, can you stop here for a minute, Ruben, so we can discuss this? I know, Leonardo Lázaro, are you here with us? Can you give us your opinion, please? What do you think about this case and these images?
I can see the rupture of the scapholunate ligament, not so clear with the lunotriquetral ligament, and you can see the DC deformity in the lunate. In the axial views, you can see when the arrows are here, you can see the lesions, right? Maybe I'll try with the arthroscopy and I'll try to perform all the reconstruction in one stage.
Okay, great. Alejandro Balsan,
Hi, everybody.
how are you doing?
Yeah, quite fine right here. Well, I can see in the dorsal capsule that there's an injury there, but I do see quite a fluid, a liquid in the LT joint. So I can say that I can both represent in the images that there is an injury in the SL joint and also in the lunate one.
Okay, great. Ruben, can you go on?
Okay, for this case, the proposed treatment was a wrist arthroscopy with a ligamentoplasty of a scapulonate ligament with internal brace in 360 degrees. For the lunate ligament, a dorsal capsulodesis with using two anchors. This is an example in a sawbone model of the technique of the 360 degrees internal brace in the dorsal and border side of the wrist. These are the videos of the arthroscopic surgery. And as you can see in the left side, we have the tunnel through the scaphoid and the lunate. And on the video of the right side, we can see the passage by the dorsal capsule to make a capsulodesis with the suture tape. And this another video. We can see a critical part, one of the critical part of the surgery, where introduced the biotenodesis screw, and the scaphoid and lunate. And the final part of the video, we can see the capsulodesis that it's made with the suture tape. For the lunate side or lunate ligament, with visualization through the MCR portal, the anchors are inserted through the MCU portal, and then one strand of each anchor is tied together, and the knot is tightened between them. Subsequently, the remaining limbs are retrieved by 6R portal and tied over the capsule. This is a visual reproduction of the technique with the 360 degrees internal brace and the dorsal capsulodesis of the lunate joint. Here we have the postoperatory X-ray, where we can see the bone tunnels of the scaphoid and lunate, and the two anchors on the dorsal side of the lunate and trigeminum.
Sorry, Ruben, I will stop you 1 second because I'm very sorry, I have the results of the polls. I will ask the question to you, to Pedro, maybe Alfonso and Victor, Gonzalo as well. Because we see for the first therapeutic option at this stage, there is no consensus because we have 10% of people, they vote for physiotherapy, 1/3 for open ligamentoplasty, 1/3 for arthroscopic capsulodesis here, and about 20% for arthroscopic ligamentoplasty. Could you just specify your point of view for each of these options, maybe Alfonso or Pedro, or just your point of view? I don't know if Pedro is here.
Yes, this is the most important issue in this type of patients because now, in fact, we have two different lines of treatment now for the scapholunate and also why not the lunate injuries. The first one is try to repair, okay, and the other one is to try to reconstruct the ligament. Probably the indication for reconstruction or repair is depending on the situation on the stage of the injury of the ligament. Probably you have only a dorsal aspect of the ligaments probably would be fine to repair only, but you have a complete tear of the scapholunate, probably it's mandatory, in my opinion, in our team, to try to reconstruct the ligament, because in fact it has to perform two different surgeries to try to repair. On the other side, in the lunate, in this side is only in the dorsal part of the ligament, not in the polar side. For this proposal, and also during the arthroscopic finding, we decided to reconstruct, complete a 360 degrees reconstruction of the ligament for the scapholunate tear, and only the dorsal aspect to repair. In fact, we try to combine two different techniques. First one, reconstruction of the ligament for the scapholunate, and repair of the dorsal aspect of the lunate. This is our opinion. About before the surgery with physiotherapy, of course, what was done, but with no satisfactory results. And also about the technique, as I said, this our indication as was proposal.
Okay, thank you.
I have a question, Alan.
Sorry?
I have a question.
Yes.
Yeah, it's very common when we have a compromise of the scapholunate ligament, and the state we comment, the comment of the Pedro is when we have in the X-rays on CT scan on MRI subluxation of the scaphoid. In this case, we don't see in the previous MRI. We don't see the subluxation of the scaphoid. And remember that the MRI and CT scan overestimate with the DC, yeah, overestimate of the DC. In my opinion, the real DC when we can see in the X-ray lateral view. This is my first question. What is the indication in the retractoscopy? I didn't see where the videos of the previous arthroscopy in the diagnosis. What is the Pedro or Ruben, the decision in this moment and the compromise of the scapholunate tear in the volar dorsal and proximal part, and compromise of the lunotriquetral volar and dorsal part? In this moment, you decided of the reconstruction, the first part, and repair on the dorsal part of the lunotriquetral. I need to see what is the compromise in my, and second part, what is the compromise of the dorsal intercarpal ligament? For me, in the scapholunate instability, the very important situation is the compromise in the radial side or ulnar side of the dorsal intercarpal ligament. My decision in retractoscopy, when we have a scapholunate instability, my direction of the treatment is the dorsal intercarpal ligament. Mm-hmm.
Yes, Rene, I'm completely agree with you, because first one, in the first MRIs and X-ray, we don't have a big instability of the scapholunate with no compromise, with no many data to have lunatic injury. But our decision was made inside the arthroscopy, because in fact you have a Gessler type 4, okay, between the two bones in the lunate and the scaphoid, and also as a small mobility between lunate and triquetum with a completely disinsection of the DIC ligament in the dorsal aspect of the triquetum. By this reason, we try to reconstruct the scapholunate and also perform the capsulodisc anchors. It's not only to reconstruct something, because in this area is not a real ligament. In fact, you try to reconstruct all the insertion of the DIC ligament. This is our proposal, because we decided inside the surgery, the arthroscopy. Sorry, because we don't have the videos, because we don't take it, but in fact, it's not the aim of the case, because the aim is before the surgery. This is the most important thing, because what do you do before this surgery?
Thank you.
Thank you, Rene and Pedro. So,
We
Ruben,
have some
can you?
questions from the
Maybe we will have Lucien. I'm sorry. The question at the end of the case. We will let Ruben present his case.
Okay.
Then later the patient is sent to rehabilitation protocol. That is the protocol of Corella, or described by Corella for the ligamentoplasty. on here start really the case, but this patient come to the office 4 months of follow-up with around a 50 degrees extension and 40 degrees flexion with a negative Watson test with persistent moderate dorsal wrist pain over the lunate joint with a click on the ulnar side. A CT scan was requested, revealing a slightly loosened anchor at the lunate. These findings were discussed with the patient and was proposed an arthroscopic revision because he present dorsal wrist pain on the ulnar side over the lunate ligament, and in a CT scan revealed the anchors loosened. So in the treatment options that were discussed are following alternatives: ligament reconstruction with tendon graft or only with internal brace, tendon graft with tendon graft or internal brace, or on the other hand, palliative procedures like partial fusion, mainly the LP fusion, or a proximal row carpectomy, wrist denervation, or total wrist fusion. The decision was made to proceed with the internal brace 360 degrees ligament, ligamentoplasty or ligament reconstruction. This is the video of the technique with the bone tunnel through the triquetrum and the insertion of the biotenodesis screw in the dorsal side of the triquetrum. And this diagram or image of a representation of the technique, where we can see that the suture tape was passed through the biotenodesis screw in the previous tunnel of the lunate, and is tied in the border part of the lunate articulation. This is the after 6 months, patient achieved a functional run with minimal pain. So, what can we discuss about this case? A lot of things, but first of all, we can discuss the characteristic of the injury. First, remember that the proximal row of carpal bone it's formed by scaphoid, lunate, and triquetrum bones that they know that as intercalate segment to the lack of direct tendinous attachment. They're together form an acetabulum for the distal carpal row and a condyle for the radius and ulna. The lunate is linked to the scaphoid and triquetrum by the volar and dorsal ligaments, being the dorsal scapholunate ligament and volar lunotriquetral ligament the strongest. When the distal row of the carpus receives an axial load, the triquetrum goes in extension and supination, and the scaphoid in flexion and pronation. Garcia Diaz described in 2017 a functional classification of the carpal ligaments. He identified 2 groups of isodynamics ligaments: the helical antipronation ligament and the helical antisupination ligaments, ulnar and radial. Mayfield described the simultaneous involvement of the scapholunate ligament and lunate together as the stage 3 in the progressive injury pattern of peronate instability that can be of greater arc with fracture or injury of bone, or lesser arc. When exists a concurrence of tear of scapholunate and lunate ligament, it's named floating lunate, described by Alejandro Badia. And later, Fernando Corella described the arthroscopic rocking chair sign for the floating lunate, or for the diagnostic of floating lunate. In this video, we can see clearly the rocking chair sign. With the probe, it's penetrating the volar horn of the lunate on the dorsal horn, and we can see the chair sign. So there are multiple studies about the treatment of isolated injuries of the scapholunate and also for lunate ligaments. In recent years, there are been some studies of the use of high resistance sutures as an internal brace. The field description of the scapholunate ligament 360 degrees reconstruction was made by P.C. Ho in 2015, and later in Kakar in 2021 adds to this configuration the internal brace augmentation by the open technique. In our team, the experience with the technique has been satisfactory, not just in radiological results, but also in functional results. On the other hand, for lunate ligament injuries, there are some studies like this technique, this arthroscopic assistant reconstruction of lunate ligament described by Hausberg, and that is a modification or a modified form of the shin technique with bone tunnels in V shape using a strip of the ECU. We have also the arthroscopic lunate ligamentoplasty described by Mr. Martinez and his group with bone tunnels also. And the antipronation spray tenodesis that was described focused in the reconstruction of the helical antipronation ligaments that are long radiolunate, palmar and dorsal lunate, dorsal scapholunate, dorsal intercarpal ligament, and the palmar scaphocapitate ligament. Is indicated in patients with chronic perilunate instability and in scapholunate dissociation with ulnar classification of the lunate. In this study, the overall satisfaction was high in all the cases. This is an open technique that needs the use of the T-wires for the stabilization of the intercarpal ligament. Last but not least, we have the S-shaped ligamentoplasty for floating lunate described by Corella and his team, which is a modification of the 360 degrees scapholunate ligamentoplasty, where he passed this suture tape through the bone tunnel on the triquetum to the dorsal side. Instead to make a 360 degrees reconstruction of the scapholunate, he make a bone tunnel on the triquetum and pass the ligamentoplasty or the plasty tendon by a bone tunnel of the triquetum and secure the scapholunate and lunate injuries. It's indicated when we have these two conditions: a complete scapholunate ligament tear plus a complete lesion of the lunate ligament, easily reducible instability. He presents 6 cases with good functional results, with 2 years of prospective follow-up, and all the patients brought the strength return to the previous sport activity. Like, we can conclude that a flooding lunate should be suspected in chronic wrist pain following trauma. The arthroscopic is an effective diagnostic and therapeutic tool. A single stage surgery allows a faster recovery. It's necessary a proper training and practice in cadaver arthroscopic course, but to manage all these arthroscopic techniques.
Thank you, Ruben. Very nice and interesting presentation.
Thank you.
So I want to hear a big final conclusion from our friend Pedro about this case, and what have you learned about this case? Because the perilunate instability is very hard to treat for everybody. What do you learn with this, Pedro?
Okay, this case confirmed to me that probably, I think in many cases is the best is to try to reconstruct the ligament, not try to repair. It's so difficult to understand what exactly happens in this case. Probably it's a mixed stage of scapholunate, rotacetum, and why not the dorsal intercarpal ligament. But probably in this case, we think that the best one, it will be to reconstruct both ligaments. You know that I'm not very agree with you about the possibility to put the fiber inside the screw, but for this case it's very important because it's only one hole, 2.5, with one screw. One of them fixed to the lunate, another one is used to pass the fiber or the suture for the other bone. It's very important because you need to increase the diameter of the bone tunneling in the lunate, because it's very special tissue that you need to confirm with the time. But what we learn with this case, try to reconstruct as much as possible in the same surgery, the both ligaments.
Thank you, Pedro. Thank you, Francesca. And then we go to Lucian for questions.
Yeah, thank you. The case was great. I was wondering if maybe with a volar capsulodesis as described by Pignal of the lunotriquetral ligament would have worked at the beginning, or as you said, it was just that the ligament was in a bad state and it needed reconstruction since the beginning. If you had known it's a question for all the team. If you had known that the dorsal LT capsulodesis failed, would you have tried the volar or not?
This is the most important key because, I prefer to perform one reconstruction with a ligament compared with 2 different repairs, dorsal and volar. Doesn't matter the technique. And about the second commentary about lunaticatum, the most important thing that the most important ligament is in the volar side. But in this case, probably you need to fix both two because there's a big instability because may cause click pain in the patient after the surgery. Probably the repair is not enough to try to fix this ligament. In fact, this is the only case we have this problem because in another case, we put key wires or sutures on one with no problem. But probably in this case, it's a big amount of stability between the two bones. It's a real floating lunate. The study could be different from other ones.
Thank you, Pedro.
Please, Ruben, could you stop to share your screen, please? Thank you. Thank you so much.
Lucian, do you have some questions and comments from the audience?
Yes, Vivian asked if it was only the dorsal part of the LT ligament involved, would you consider only to repair only the scapholunate as it's the dorsal part of the lunotriquetral ligament? Pedro?
Yes, because In this case, the most important thing in this case is not the fact the MRIs or the fitness, is the symptoms of the patient, because the patient have symptoms in both sides, in scapholunate area and also the radioticated area. And also the first surgery was performed by another team only for this lunate instability. For this case, try to repair the ligament, but in all cases, with no problem, with no symptomatic findings, we don't perform anything in this type of tears.
Okay, another question was what is the best indication for the 360 reconstruction, and a technical detail, what kind of how big are the holes and how big is the biotenodesis screw?
Okay, because in fact, our indication is patients with a stage 3C of the IWC classification, or 4 or 5, with a complete tear of both parts of the ligaments. We try, and also our technique is a mixed technique with repair ligamentoplasty, because we use something artificial, not natural, like a suture that try to involve the capsule as a biological support. It's a mixed technique between ligamentoplasty and capsuloplasty. Second one, about the size of the holes, is 2.5. It's an out. It's a minimal aggression to the bone. And about the fixation, always the same. Because when you have a tendon graft, it's due to be minus 3 millimeters, but it's only in one view. If you try a circumferential view, it's very difficult to assess the total diameter of the bone grafting. In this case, always the same suture, the same bone tanning, and the same screw, 3 millimeters screw. It always the same sensation, to have big sensation of fixing during the surgery. No worries, it's safe. It's the same technique that a tendon graft reconstruction with a minimal invasive diameter of the bone tanning, but the other one is the same. And in our experience with more than 8 years of prospective follow-up, we have any problem with this type of technique. I know it's a very special issue because there are many publications around this, but for us, in our hands, we have no problems. That's vascular support and osteonecrosis.
Okay, the last question was the vascular supply problem of the lunate with the hole, but you answered on it, so no more questions.
Thank you.
Somebody commented, let's go to Madrid, the risk course in 2026.
Yeah, in February. We are waiting you. Okay.
Some advertising.
Also, we are going to discuss this type of indications because I think
Yes.
this is a real problem. We need to have a good protocol for treatment for all these cases. It will be the next step in the next Madrid course.
Okay.
Gustavo, do you allow me to make a comment, please?
Yes, of course. You are the queen.
Okay. Thank you for the case. It's very interesting. Actually, we have frequently this kind of floating lunates. Personally, in my experience, I try to do the less difficult, so not so good in internal brace. That's why I have to go to Madrid course to learn every year. I do in this, to be totally honest, in this kind of case, I think first the diagnosis is confirmed by the arthroscopy. We need to focus on this because differential diagnosis clinically and even with the imaging before is very difficult. We can dismiss the diagnosis. When I confirm intraoperatively the diagnosis, I try to do my best with dorsal reinforcement. You know how I love this kind of techniques on both scapholunate and lunotriquetral spaces, and I adapt the kind of reinforcement. For example, if I have 3C on the lunotriquetral space, I do a large reinforcement, and it works better on the lunotriquetral space than on the scapholunate space. I assume that is because the DIC have a strong insertion on the ulnar side. My question is, we have two different techniques. I think your technique is very, very good, very strong. I follow my patient post-operatively mainly with the clunk, with the clinical instability. I would like to ask you, Pedro, and all the team from Madrid, what is your main parameter to decide that your technique failed for the first one? Is it clinical parameter? How do you decide that? Because you have a patient is not so bad after the first surgery. How do you decide that it failed finally and you have to reoperate the patient? For me, it is mainly a clinical decision, sorry, to say that it failed. A pain on the lunotricuspid space, a remaining clinical instability is enough for me most of the time to decide that my technique failed.
This is a very important commentary because it's very difficult to assess or to prepare the diagnosis only with MRI of CT scan, X-ray, because in fact, lunotricuspid injury is very difficult to confirm with this test. The most important thing in these cases are the exploration, the anamnesis, and for us to try to decide a second surgery because it was very difficult for us was the pain in this area and the clank. We touch and we had the clank of the patient, and the patient said to us, "Sorry, doctor, I'm fine for this area, but I have problem with prepare the ulnar deviation, have a clap," and the patient shows clap, clap. Sorry, because probably we need to have these videos during the presentation, but we think the most important thing for this case is to discuss about the reconstruction of both ligaments, diagnosis, and why not the postoperative treatment. But I am the same opinion as you. The most important in this case are the exploration of the patient. And of course, you need to confirm the diagnosis during the surgery using arthroscopy, of course.
Because most of the time, if you guys, all the attendees, you have this kind of patient, you will wonder if it's not, I don't know, a mid-carpal instability or something like this, and ask for this dynamic CT scan. So I think we need to focus on the arthroscopic exploration. Yes, that's it for me. Thank you. Gustavo.
Great, Alam. So I don't know if do we have more time or?
Yes, if people they want to comment in the panelists, if we have some question, we have 5 minutes, and after we will say goodbye.
I have a little bit comment. I totally agree with the comment of the Alfonso and Pedro with the size of the channels is very important, right? In my opinion, I have an experience with the choroidal reconstruction in 18 patients, and my technique, technique of the APLIR, arthroscopic lunate stability reconstruction, when we use the 2.5 until 2.5 size of the channel. I put 3 millimeters of the bone graft and fiber tape. It's the same. And the most important is this point. And the second is the diagnosis of the compromise of the subluxation of the scaphoid, repeat the same, and compromise of the dick ligament. In this point, it's very important what decision of the treatment and the final treatment you use. And the technique of the Pedro of the LT reconstruction is very important. We know what ligament remains in the arthroscopic view when I see LT ligament in the volar and dorsal part, blood or not blood. Yeah, you understand me? Is reparable or not reparable? This is the most important. When we have, it's not common. We have a compromise of the LT, chronic compromise of the LT ligament. It's very difficult decision what is the treatment. I have in my experience 4 cases when we have a compromise of the scapholunate and prelunate and chronic the injuries of the scapholunate and LT ligament. The decision is reconstruction or repair depends of the blood and or synovitis in the zone or when remains of the ligament we have. This is my opinion, my experience.
I agree. Thank you.
Very good. So Alfonso, Victor, Gonzalo, do you want to add any more last comment?
Well, I think that the Alam said perfectly. I think the arthroscopy is the most important thing to understand this kind of injuries. So we can ask for CT scans and MRIs and so on, but there's nothing better than arthroscopy. And I think it's a very good weapon because it's very safe. And you can see perfectly all the ligaments, all the injuries. So you can decide in the arthroscopy, or even a little bit late. So you perform a diagnostic arthroscopy, and then you discuss with the patient how are the treatments, and then you can have a personal treatment for your patient. So I think this is the most important question, or the most important thing in this kind of difficult cases.
Great. Okay. Thank you so much, Alfonso. Thank you so much, Ruben, for bringing us this beautiful case. And Alan, do you want to close the webinar?
Thank you, Gustavo, Lucia, and everyone for preparing these beautiful cases that are very interesting. Thank you to all the speakers, the attendees. So I just have to wish you a beautiful summer in Europe, because we are on holidays, not for you, I'm sorry, in Argentina and Chile. So the next webinar, I hope everyone enjoyed this discussion. Next webinar will be last August or in the beginning of September with the same team. And once again, thank you. And have a nice weekend. Bye-bye. Thank you.
Thank you. Bye-bye.
Bye. Thank you.
Bye-bye.
Thank you, everybody.
Everyone.
Bye-bye.
Goodbye, buddy. Goodbye, my friends.